Welcome to this BTOG podcast. My name is Tom Newsom-Davis. I am the chair-elect of BTOG. This is part of our regular podcast series entitled BTOG Does, where we have informal chats with experts in their fields and tackle the most important questions we all face in the diagnosis and treatment of thoracic cancers. It is important to say that sponsors of BTOG do not have any role whatsoever in the planning, delivery, content of anything discussed today. Hello, everybody, and welcome to another BTOG podcast. I'm still Tom Newsom-Davis, medical oncologist at Chelsea and Westminster Hospital and chair-elect of BTOG. Here we are 1 month before our BTOG annual meeting, and for this podcast, and I hope for future podcasts, I'm absolutely delighted to be joined by my colleague Emma O'Dowd, who is a respiratory physician in Nottingham. And Emma's going to be joining us generally on the podcast and giving us more of a respiratory slant on them going forwards. But today we are firmly in medical oncology world. We are finishing our series on the rarer mutations affecting lung cancer patients, and we're going to focus on HER2 mutations and all things HER2. And I'm equally pleased to be joined by my friend and colleague Riyaz Shah. Riyaz is a big friend of BTOG. He's been on the steering committee for a long time. He's done numerous educational activities for us. He's a medical oncologist in Kent. Riyaz, thank you very much for spending your evening with us and discussing all things HER2. So, first of all, I'm going to ask you, Riyaz, if you can help us work out the difference between a HER2 mutation, a HER2 amplification, and HER2 overexpression, because sometimes we'll see all different things in reports. Can you explain to us roughly what the difference is?
Yeah, so what we're talking about here is the HER2 protein, also known as EGFR2. So this is the EGFR family, EGFR 1, 2, and 3, and 4. EGFR1 being the EGFR that we talk about with EGFR mutations in lung cancer, where we treat patients with osimertinib. But what we're talking about here is EGFR2, also known as HER2. And we know that it's signaling from this kinase receptor can alter cellular behavior. And we know that there are a range of mechanisms that can drive that. So one of them is lots of protein, so excessive protein expression on the cell surface. Now, protein you would pick up conventionally with immunohistochemistry. Or you could get gene amplification, so multiple copies of HER2, and obviously driving excessive kinase activity through that. Or we now know that that you can get mutations, just like you get mutations in EGFR. You get very similar, almost analogous mutations, albeit different in some nuanced ways, in HER2. And we know in the context of lung cancer patients, a small number of patients, let's just say ballpark figures 2% or less, have gene mutations in HER2 that drive the expression of a protein that has a amino acid sequence change that causes constitutive activity of the kinase.
So the overexpression is what our colleagues in the breast cancer world are picking up on their HER2 testing. That, as we will discover, is a little bit of less relevance to us. What we're really going to primarily focus on is going to be those HER2 mutations. And you make a very good point about it being the same family as EGFR. So I would advise my colleagues when you're looking at your pathology report, just make sure when you're reading the gene and you think someone's got an EGFR mutation, there may actually be a HER2 mutation, depending a little bit how it's written. Okay, so if we're going to look at overexpression, we would do that through immunohistochemistry, as you say, but I'm going to put that to one side because that's not currently so relevant in the lung cancer world. Riyaz, what do you think is the best way of diagnosing someone with a HER2 mutation? What would be your go-to test?
Well, there isn't a simple so we in the context of lung cancer, we're interested in the mutation, right? We're not interested in amplification or overexpression. To detect the mutation, you essentially need to sequence the gene to see if there are mutations. So there's no really good antibody that will pick up a mutation. I'm not sure what the scenario is with PCR-based systems but I don't think any of the conventionally used ones I've come across cover HER2. So
Hmm.
if you're doing an in-house COBAS or a DILA, I don't think it would report a HER2, so you would miss them. And the only real genuine way of picking these up is to do next generation sequencing.
Okay.
And remember that there are two main mechanisms in the NHS in England through which we can get next generation sequencing. That would be on tissue through your local genomic hub or
Yeah.
on liquid.
Yeah. And we should remind people it's going to be in the DNA part of that NGS as opposed to the RNA.
Very
And
much.
I absolutely agree with you that you will pick these up on ctDNA if you have access to that. If you're not part of the NHS England ctDNA pilot, I would encourage you to do so because it can be very, very helpful. So that's how we're going to pick it up. We're going to make sure we've done proper NGS. And if we're not doing proper NGS, if we're doing PCR-based assays, individual gene tests, we're probably not doing a proper analysis of the tumor biology. You work in a great center. You've got your testing up and running. If people are thinking about HER2 mutation patients, who are these patients? You said it's rare. It's 2%, so it's down the kind of the small end of the pie chart of all those mutations we see. What's the general demographics in terms of gender, smoking, non-smoking, age, that kind of thing?
So, Tom, I think, yes, you can make generalized statements like EGFR that it's predominantly female,
Hmm.
predominantly never smokers, um, and predominantly adenocarcinoma. So I think the phenotype of your EGFR ALK ROS1 patient is probably going to be the phenotype of your HER2 mutant patient.
Hmm.
But you always get exceptions. So the important
Yep,
thing is to test everyone.
absolutely. And I think reflex testing, as we've banged on about for many a week, is the way to do it. So anyone can have it, although we might suspect it more in the younger female never smoking
Correct.
patient. Um, we'll focus on the HER2 mutations. One thing we don't use is Herceptin on this patient group that has no um, meaningful activity in the lung cancer group. But there are drugs, antibody drug conjugates, which have got some activity, some more than others. Could you tell us a little bit about those and the kind of patient groups that you've been using? I guess I'm really thinking about the trastuzumab-based antibody drug conjugates.
Yeah, so this is an evolving field. There are a multitude of antibody drug conjugates that are currently being developed um, to target this particular mutation.
Hmm.
So fundamentally, at the moment, there is a licensed product in breast cancer. So this is trastuzumab deruxtecan
Hmm.
that has trial data showing activity in HER2 mutant lung cancer and appears in guidelines, NCCN and ESMO guidelines, as a potential treatment option, although it is not currently licensed or reimbursed in that setting. It
In
might
the
be
United Kingdom.
licensed. I don't think it's licensed in the
Mhm.
United Kingdom.
And it's certainly not reimbursed in the
It's
United Kingdom.
certainly not reimbursed. So this is an antibody drug conjugate. So everybody who's listening to this to understand what that is, this is the idea that you have an antibody that targets something. In this
Hmm.
case, we're going to pick HER2, and
Hmm.
we connect a cellular poison to that antibody via a linker. And so the antibody takes the cellular poison to the cancer cell, it binds the cancer cell will uh, um, internalize that
Hmm.
antibody, and then the cleavable linker will come off, releasing the poison, the cellular poison. And there's a huge amount of chemistry here. You can use different antibodies, different linkers with different poison payloads, and they all have nuances and interesting toxicity profiles about them. But trastuzumab deruxtecan is a ADC with trastuzumab, Herceptin essentially, with a cellular poison called deruxtecan. And it's given infusionally once every 3 weeks.
So trastuzumab deruxtecan is a drug, as you might imagine, that originally has had its data shown in breast cancer, but we also have good data of it working in lung cancer. Those tend to be the Destiny lung studies. I wonder if you could just tell us a little bit about them in terms of who do they involve, what line of therapy, and how effective is this drug?
Yeah, so the Destiny studies are basically Destiny Lung 01 and Destiny Lung 02. So trastuzumab deruxtecan was given open label to a group of patients with known HER2 mutations. Two different doses were tested, 5.4 milligrams per kilogram and 6.4 milligrams per kilogram. And they've seen activity at both dose levels. So just to give you a flavor of what you might see, Destiny Lung 01 has something like 102 patients. Overall response rate about 54%, and a disease control rate of about 90%, which is not bad at all.
Yeah, very high.
Median PFS of 9.9 months. So I think very clear that this drug has activity. And if you were to look at the ESMO guidelines, they would suggest that a patient access this first or second line, actually, because obviously there are a group of patients in whom this is not picked up until they've already initiated standard first-line therapy. In fact, that's not uncommon at all. So a good number of these patients would get chemo-IO first line. The HER2 mutation is found, and then ESMO guidelines would suggest the next treatment of choice should be this, TDXD, which is the shortened acronym for trastuzumab deruxtecan.
That's a very active drug. I mean, that disease control rate is very good. The unusual way they've had two doses, a lot of that reflected concerns about interstitial lung disease. And that appears to be a side effect driven not so much by the antibody as by the toxic payload. Am I right in saying that the lower dose they found equivalent efficacy but less ILD reactions? Is that a reasonable summary?
Yes, I think so. So, TDXD has a toxicity profile. And if you were to look at the trial data, something like 38% of patients have a grade 3 or more toxicity event while they're on it. ILD is the thing that the community is most concerned about. And at the 5.4 dose in Destiny Lung 02, they reported an ILD rate of 6% versus 14% in the higher dose. But importantly, this is an adjudicated as drug-related ILD. So it's not what was clinically thought to be ILD, and so those figures are probably higher.
Yeah, absolutely. So I think ILD has been the kind of one of the concerns about this drug, although reassuringly at the lower dose, more manageable. Unfortunately, we don't have access to this agent, although it does have clinical activity. So practically speaking, Riyaz, when you're sitting in clinic and you have found out a patient has HER2 mutation, outside of clinical trials, presumably you're giving them first-line platinum-based chemotherapy. Is that a reasonable accusation?
Yes, so I think that's absolutely fair, and that's an area where I have been conflicted, because the thing with TDXD, it's not available, but you never know when it might become available, and you never know when there might be an access scheme that might make it available. So it's influenced my first-line prescribing. So because of the concerns about ILD, I went through a period of not giving immunotherapy to these patients, because I was concerned that if they progressed while on immunotherapy and then switched to a TDXD-like agent, I would have to deal with, potentially very serious ILD toxicity. But interestingly, there is some data, it's retrospective data, to suggest that people with these mutations do better with chemo-IO than chemo, but it's retrospective, and I wouldn't read too much into that.
Interesting. I did exactly the same as you, and I was just giving chemo without the immunotherapy, and based on that data you just mentioned, suggesting maybe adding in the IO may still be helpful. I've gone back to that because I don't have any optimism. We're about to be getting trastuzumab deruxtecan for our NHS patients, unfortunately. Now, trastuzumab deruxtecan is not the only antibody drug conjugate. It's a drug combination called TDM1 that was used a little bit less effective, but that really never made it out into the commercial space. And there are some other antibody drug conjugates in development, but I think it's fair to say trastuzumab deruxtecan remains the main player. We hope to have it in the UK, but I don't see that happening in the immediate future. There are other approaches, and people with a long memory will remember a number of tyrosine kinase inhibitors or TKIs being developed in this area quite a few years ago, pre-COVID, which is my definition of quite a few years ago. Poziotinib was one of them. It was a very toxic drug, lots of GI side effects, lots of cutaneous side effects. And it was a drug that seemed to be okay when it was in early phase trials in very specialist units. And then as it was moved into the phase 2 and later trials, really the toxicity became more and more apparent. So that kind of fell by the wayside. But I think a lot of excitement has been generated more recently by the arrival of newer TKIs targeting HER2. And I guess two I'm thinking of, but not the only two necessarily, Riyaz, would be zongertinib and a Bayer drug beginning with BAY. Could you maybe just a little bit about this new generation of TKIs, and could you summarize the data a little bit about what we're seeing with these new agents?
Yeah, so now we're talking about tyrosine kinase inhibitors. So we're talking about orally available drugs, just like alotinib, osimertinib, etc. So zongertinib is a really interesting drug, as is the Bayer compound, Bay 2927088. We'll just call it Bayer for the rest of this chat. They are different. So they're both oral tyrosine kinase inhibitors. The Bayer drug is a reversible kinase inhibitor. Zongertinib is a covalent inhibitor, and it's designed to be more EGFR wild type sparing. So the thing about, because I said right at the beginning that EGFR and HER2 belong to the same family, these kinase inhibitors have some effect on normal EGFR. And so these TKIs have some of the toxicities that you get with EGFR blockade. So if you think about the first generation, second generation EGFR inhibitors we were using, like gefitinib, alotinib, afatinib, the rash, the diarrhea, paronychia, etc. So developing a HER2 TKI that's wild type sparing for EGFR is actually quite an important sort of goal in this. So we've got two drugs. Both have reported results. So there's a trial called B-Mayan Lung 01 for zongertinib and Soho 01 for the Bayer compound. And really, really interesting results. So if we think about, I quoted you for TDXD 54% response rate in Destiny Lung 01, well, zongertinib 75% and the Bayer 72%. So disease control rates comparable, 90% for TDXD, 93% for zongertinib, and 84% for Bayer. But very high, I think you're seeing a consistent signal there of a higher response rate. These are very, very early studies and they're still ongoing. So we only have a small snippet of data. The duration of response for TDXD and zongertinib are not reported or not evaluable at the moment, but Bayer's reported 8.7 months, PFS of 7.5 months with Bayer, and 9.9 months with TDXD. But I think I've not seen any reports in any of the stuff that I've seen at meetings reporting ILD as a dose-limiting toxicity for either of those drugs. And so for me, that's very, very tantalizing.
And I think there is a difference in terms of side effect profiles. I think zongertinib is a drug that is well tolerated. The Bayer compound, as you say, does tend to hit wild type more. In fact, it was originally developed not as a HER2 targeting agent, and because of that, hitting the wild type, it is associated with more of the GI side effects like rash and diarrhea. But I agree. I think these are very active drugs, and we would look forward to hearing longer mature data and seeing that duration of activity. One thing that I noticed looking at it is with these agents, unlike with trastuzumab deruxtecan, you actually want to look at the particular mutation, because the mutation you have is going to influence how well the drug works. So the audience might want to look at that particular mutation subtype. And there's one particular one called YVMA, and that YVMA subtype is the one that is probably most sensitive to these mutations. And so knowing where the mutation is on the HER2 receptor is going to be a very important part. The drugs are in early phase clinical trials. We look forward to seeing more. I guess we might see more this year, Riyaz. In 2025, we might see some more data coming out. Were there any side effects in that lot that concerned you, or did you feel, for example, for the BMEON studies of zongertinib, that those were all kind of manageable and acceptable?
Yeah, I mean, my analysis of the toxicity profile just makes me think zongertinib is a bit easier to give. So if you look at what percentage of patients had a dose reduction, so zongertinib 11%, Bayer 32%. So exactly as you say, it feels like the Bayer is not really wild type sparing. So you see quoted rash, diarrhea,
Yeah,
paronychia,
yeah,
stomatitis.
yeah,
These are tough side effects.
yeah.
But the one thing going for it, the treatment discontinuation rate is quite low,
Mm,
6.8%.
mm,
So it makes me think that perhaps a bit like afatinib, it's an active drug. If there's a good dose reduction schedule
yeah, yeah,
with different tablet strengths, it might be deliverable in clinic, in routine practice. And I think a significant number of patients are going to need a dose reduction. When you look at zongertinib, treatment discontinuations are very low at 3%, and the dose reduction rate is 11%. And then grade 3 toxicity, the published grade 3 toxicity rate for Bayer is 43% in SOHO 01 and 17% for zongertinib in BMEON. So, I mean, I just get the sense that the zongertinib is an easier drug to give, but we're making comparisons across trials that are not randomizing patients to these different options, and there are huge biases in making these assumptions.
absolutely. Do we have any intracranial response data? I must say I don't know that. I'm not sure we've got that available. You may know.
No, there's a little bit of data, I think, from SOHO 01. I mean, they're active in the brain.
Yeah,
And I think actually, before we get on to that, I would say that that's another really important part of these patients. These patients have a propensity to develop brain metastases like EGFR, ALK, and
yeah,
ROS1 patients. So they
yeah.
need brain surveillance. They
They do.
need
Yeah,
aggressive
very
brain
good point. Yeah,
monitoring and aggressive brain treatment. I think ultimately, I suspect, if you're asking me to guess, I think the TKIs are going to win probably
yeah,
versus ADCs, because I kind of have doubts about what brain penetration for an ADC is going to be like. I mean, I think ADCs will have activity in the brain um, when the blood-brain barrier is disrupted, but I think, will
yeah,
they be neuroprotective like TKIs? We see effective CNS active TKIs actually prevent you even developing brain metastases across different actionable genomic alterations like ALK and ROS1. I wouldn't be at all surprised if we see that in
Mm.
this disease.
So in fact, we could see a situation where we might be perhaps using our TKIs in the first line. We've known from multiple mutations now that if you've got an effective, well-tolerated TKI, use it up front. There wouldn't be any particular reason, let's imagine the wonderful world where all drugs are available, that you couldn't use an antibody drug conjugate after your TKI. There's no reason why you should get cross resistance. I mean, we've got no evidence behind that, I hasten to add. But if you've got an antibody drug conjugate and a TKI, maybe one would use them sequentially.
Well, I think the issue there is going to be overlapping toxicities and
Yeah,
what is the ILD rate. The ILD
yeah,
rate uh, for osimertinib in someone who's had IO first is
mm,
is very high. It's 4 or 5% or less in routine practice. I think it's tens of percent. Uh, so I think there are dangers to that. I wouldn't make that assumption at all. I think all of these are being tested in the first line setting versus standard of care. So there's a first line BMI and Lung O2 trial running and recruiting in the UK at several
hmm,
centres.
yep,
There's a Bayer trial called Soho Lung O2. I don't know if it's recruiting in the UK. And Destiny Lung O4 is testing TDXD in the first line setting. So if you pick one up in your clinic, ring
definitely.
your friendly, engaged medical oncologist and find out where there will be a trial open for your patient as long as they're willing to travel. And I think travel will be reimbursed.
Yeah, I think it's a really, really important point because at the moment we don't have access to targeted drugs, and patients will miss out. And I agree that most trials will reimburse Travel. So that's our situation on HER2. We know about how to diagnose. We know the mutation types. If someone picks up HER2 overexpression or amplification, at the moment they're not going to make a treatment decision based on that. It may be of interest. There was some original data with trastuzumab deruxtecan on HER2 overexpression. There's even a little bit of data on some of the TKIs. But I think it's fair to say at the moment that would not be something we would regard as an actionable alteration. Riyaz, to summarize, what's your prediction on what's going to be the most effective way of targeting HER2? And if you had a magic wand that in 3 years we had, or 5 years, we had access to these drugs, where do you think we might be optimistically in 3 to 5 years?
Well, I think TKI therapy will become standard of care, and I do think some antibody. I mean, if you think about EGFR, we're using osimertinib. We know that amilasertinib is a better treatment. We know there's an overall survival benefit now, although we haven't seen the data. We know the press release is out. We know that amivantamab chemotherapy after osimertinib has effectiveness. This is a very similar, receptor. So I think the story is going to evolve, and we're going to know in the next 5 years what is optimal first line therapy versus current standard of care. And then I think once we've established that, then we'll start looking at acquired resistance. That's going to be a piece of work. What are the mechanisms of acquired resistance? Are they on target, off target? Do you see small cell transformation, EMT? Do you need to rebiopsy patients? And what are the strategies to develop subsequent therapy? So this is going to turn into a very interesting new tumor site for lung oncologists. The only thing I'd end with is just to highlight, just be careful when you read your liquid report, when you read the report from your GLH, because sometimes the way these things get reported may not be obvious to you that what you're looking at is a HER2 mutation. Absolutely. And most of these are what we call exon 20 insertions. And so, if you see anything mentioning HER2 mutation, it's worth doing a bit of research if you're unsure. 775 is the key number. If you see anything involving 775, that's a YVMA exon 20 insertion, more than likely. Google is incredibly helpful. If you type a mutation into Google, usually on the front page, it will tell you exactly what that is.
And I think that's a really good point. The other thing to say is, if in doubt, you can phone up the number on your laboratory report, and you'll have a very helpful discussion with your
and GTAB, obviously,
scientist.
yes. Let's not forget the GTAB.
Let's not forget GTAB. Riyaz, thank you very much. That's a tour de force. Thank you very much for covering all that. So the things you might want to remind ourselves of is that these are rare mutations, but they're really important ones to pick up, because we do have potentially effective treatments. Read your molecular result carefully, and you do need NGS to be picking this up. We don't, unfortunately, have licensed drugs available, but if you pick up a HER2 mutation, see what trials are available locally. We do have antibody drug conjugates. They are interesting. They are active. Interstitial lung disease is going to be perhaps their Achilles heel, but maybe the most exciting is the arrival of the next generation of TKI, zongertinib and BAY88, which are beginning to show their benefit. We do need some more data before knowing exactly how effective, but I would agree with Riyaz, if I was a betting man, I would see these coming into a first-line treatment, I hope, in a couple of years. Thank you very much all for joining us. Welcome, Emma, to the team. And Riyaz, thank you very much for giving up your Tuesday evening to discuss all things HER2. For more information on BTOG, including education events and how to become a member, you can visit us at www.btog.org.